Good evening, everyone. So today I'll be discussing how to choose fluids and inotropes in the ER. There are umpteen number of reasons why we write a fluid, right? It may be someone you want to start a replacement because someone is vomiting. And again, the vomiting may be a bilious vomiting, it may be a hematemesis, it may be an ileostomy stoma, which is producing a lot of fluid loss to the patient. Or it may be a patient in shock due to varying conditions. So there are so many reasons why we write an IV fluid. So today, this is exactly what I want to discuss. That is, what would be the ideal fluid in each clinical scenarios that we come across. And before we discuss anything about the fluid, always remember that fluid is the drug which has been reported with maximum number of adverse events. What does that mean? Use it only when indicated, and when you're using it, use it appropriately. Choose it rightly, give the right dose for the right duration. So with that, let us come to today's topic. Okay, so this is the topic, that is choosing fluids and inotropes in the emergency room. So what I really plan to do in the next 20 minutes or so would be, through a few clinical scenarios, we would be discussing how to choose fluids. That is, clinical scenarios that we commonly come across in the emergency room, which may range from a simple vomiting to a septic shock or a dengue. So now coming to the first case, 10-year-old child presenting with fever and vomiting, and there are no meningeal signs. That is, your clinical diagnosis here is viral fever with gastritis. You've already given a pantoprazole and an Ondine syndrome, that is MSH. He gives history of not passing urine for the last 8 hours, but there are no signs of shock and there is no hypoglycemia. So the first question is, does he really require a fluid? But now you can say that you have tried your medical management, but the child is not tolerating fluid. So it feels justified that you need to write a fluid. Now, if you are going to write a fluid for this child with probably some dehydration there or not passing urine for 8 hours, even though there are no clinical signs, and you have tried your ORS also and it is not working, which fluid would you opt for? First of all, whenever you have a child who's presenting with vomiting with fever, always rule out meningitis. Go again and check if there are any meningeal signs. See to it that you're not missing a surgical abdomen. Then, of course, many a times, especially smaller children who come with recurrent vomiting, which is not responding to your pharmacological management, is often a forerunner of diarrhea. That means the patient is having acute gastroenteritis, but right now only the vomiting has started. And once the diarrhea sets in fact, many a times the vomiting comes down. So always ask for whether there is a history of constipation or if the patient has passed stools on that particular day. If not, just keeping a Dulcolax suppository might help you come over or avoid giving an IV fluid. The vomiting may subside just by that. If not, any child with a viral fever, with a suspected gastritis, who's having recurrent vomiting, not responding to your treatment, always think of starvation ketosis also. You can just rule out a starvation ketosis by checking for the urine acetone. If urine acetone is positive, that means the patient has not taken anything orally or has taken orally fluids which did not contain carbohydrate, and because of which his lipid is getting metabolized and has landed up having a starvation ketosis. So when you have vomiting due to starvation ketosis, the vomiting usually would subside only when you have replaced the carbohydrate. So not only about hydration, it is also about providing adequate carbohydrate to the patient. So in such a situation, this is one of the commonest situations that you're going to encounter. The preferred fluid would be DNS. You can give it anywhere between 3 to 5 ml per kg per hour for just 2 to 3 hours, and you'll find that the vomiting subsides with that. So every time for a vomiting, if you're putting a cannula, some basic investigations apart from the glucose level would be to look for the electrolytes as well as renal function test. And here, always remember, add potassium chloride if you find that the patient has passed urine or if the RFT is normal. That means if you're not encountering a renal failure, when you're vomiting, you also lose a lot of potassium. So adding potassium to the fluid will also be good. So from there, now what about children who present with bilious vomiting, or someone who has a bilious aspirate, or someone who does not have a bile stained aspirate, but there is a lot of gastric juice coming out, or a baby with an ileostomy, there and you are having a lot of stoma loss leading on to dehydration, tachycardia, how do you decide which fluid to give? The guidelines tell you that if the loss of fluid by the aspirate is more than 10 to 20 ml per kg, then you need to replace ml by ml. So that is every last 4 hours, you will see how much fluid has been lost. And the same fluid, you would replace it over the next 4 hours. So every 4 to 6 hourly, you can look for the loss and replace accordingly. Most of the guidelines tell you that the fluid of replacement is normal saline with potassium chloride, and measure electrolytes periodically and adjust accordingly. But on a practical side, we need to know what exactly we are losing when we are having these kind of clinical scenarios. So remember that your gastric aspirate contains a sodium of around 70 with a lot of chloride. So here the fluid of choice would be either a normal saline with a potassium chloride or a half NS with a potassium chloride. So I would say if it's a bigger child, just replacing with NS with KCl is okay. But if it's a small child, probably starting with a half NS is okay, and then titrating accordingly should be more physiologically better. So you can, so the final this thing is you can either use half normal saline or you can use normal saline. Decide on which fluid to continue depending on the repeat electrolytes, but always the chloride needs to be there. On the other side, if you have a patient who's had a bilious vomiting or who has an ileostomy, which is draining too much of fluids, here the fluid of choice, in fact, would be probably a ringer lactate, because this would provide you with some amount of potassium, would provide you with the bicarbonate source also. Because bilious vomiting, bile, pancreatic juices, and ileostomy contain significant amount of bicarbonate also. Here again, I repeat, if you want, you can replace with normal saline itself and then follow up the results and adjust accordingly. But you can also think of straight away going to ringer lactate and then adjusting accordingly. So from there, we move on to the next case. Now, it is not uncommon to get a child with a hemorrhage in your ER. So it may be a child with an upper GI bleed coming to you in a hemorrhagic shock. It may be a child with a road traffic accident coming to you in a hemorrhagic shock. So whatever be the reason of a hemorrhage, whenever a patient presents with shock, we need to remember that he has already lost 25 to 30% of the blood volume. Only then the BP falls. And remember, the immediate cause of death for this child would be hypovolemia and not anemia. So your priority is definitely to restore the cardiac output first. So always we start with a crystalloid, that is normal saline bolus. But most importantly, don't go on repeating your normal saline boluses if the BP has not picked up, because remember, when the child has lost, it is not only the RBC the child has lost the plasma proteins, the clotting factors, everything has been lost. So when you replace all those things that has been lost only with a crystalloid, you may land up creating a dilutional coagulopathy. So ultimately, you will have a child whose BP is normal, whose BP has picked up, but is coagulopathic, and you don't have space to give the coagulopathy, to correct coagulopathy by using blood products. So that is why first fluid is always normal saline. If you require a second bolus, please ask for a blood and always transfuse blood. So that is important. Do not give too much of fluids. Similarly, do not start inotropes when you have a hemorrhagic shock, because this is basically a hypovolemic shock. There is no water in your tank. When there is no water in your tank, there is no point in switching on the motor. So please do not start inotropes routinely. But if you have a child in profound shock, absent pulse, you may start an inotrope early, thinking that he may go into cardiac arrest anytime to prevent cardiac arrest. But as soon as possible, please taper and stop, because they're not recommended. Because always remember, in case of a hemorrhagic shock, it is always permissive hypotension. When you try to increase the BP by starting a vasopressor, on one side, you may be compromising the perfusion. On the other side, you may be causing the dislodgement of the clot that is formed, which may again lead to a rebleeding. So avoid using inotropes as much as possible. And whenever you are encountering a massive bleed, that means in a child when the amount of fluid required is, or blood required is more than 40 ml per kg, always go for 1:1:1 transfusion. That means 1 unit of PRC followed by 1 unit of FFP and 1 unit of platelet, that is appropriate to the weight of the child. And when you're using these, always remember, in case of a hemorrhagic shock, Your target is a hemoglobin of 8 gram per deciliter. Ensure that the PTINR is less than 1.5. The platelet count is more than 75,000. Please check the fibrinogen also. It needs to be more than 150. If it is less than 150, consider transfusing cryoprecipitate, and always try to keep the pH more than 7.2. Remember, acidosis, coagulopathy, and hypothermia is a deadly triad as far as trauma or a hemorrhagic shock is considered. So always see to it that your baby is not hypothermic. Always check for the blood gas. If there is acidosis, giving a bicarbonate would also be justified, just in the sense that you want to control the bleeding. You don't want the hemorrhage to worsen. And also remember that if it is a road traffic accident with the bleeding, definitely adding tranexamic acid early would have a role. And always look at the ionized calcium. Ionized calcium should be more than 1, because here whenever you're using a PRC transfusion, you have the anticoagulants there. The citrate will bind to the calcium. The total calcium would be normal, but ionized calcium will be low. And when your ionized calcium is low, naturally, it interferes with the clotting, because calcium is needed for the coagulation cascade. So always when you're checking the blood gas, please check the ionized calcium, especially if it's less than 0.8, to correct hypocalcemia. So these are the goals when you're dealing with a hemorrhagic shock. Now moving to the third case. This is a child, 3-year-old, who's presented on day 1 with fever. On that day itself, they have checked the blood, and NS1 is positive, the time of the dengue outbreak. And so they have prescribed some symptomatic management and sent back. And again, the next day, the child is brought because the parents are very much worried, because they know that the child is having dengue and intake is poor. So the child is admitted and child is started on Isolite P. On day 3, he again has 2 episodes of vomiting. And so the maintenance fluid is continued. And while on maintenance fluid itself, the child developed shock by the evening. It was hypotensive shock. It was resuscitated with 2 fluid boluses and referred with a BP of 90/60. Now, at admission, the child you find is still febrile. The BP from 90 systolic has now decreased to 80 systolic, but still it is above the 5th centile. But the child is looking puffy. There is mild tachypnea. Air entry is decreased on the right side. An X-ray is showing a pleural effusion with a saturation of 90% in the room air. With a nasal prongs itself, it has improved to 94%. So basically, you can say that you have received a child in a compensated shock with a respiratory distress, not a very bad vitals, you can see. But the most important thing you have to remember here is that your child has just entered the critical phase. That means his leak has just only started. His leak is going to progressively increase. And he's again going to go into shock. And when he again goes into shock, you would require to give fluid boluses. When you give fluid boluses, the respiratory distress, which has already set in at the onset of critical phase, is going to worsen. And when it worsens, it's going to be from the non-invasive ventilation. He may land up in an invasive ventilation. So unfortunately, these times the leak will be continued. So what is going to happen? While you're trying to manage the shock, the respiratory part will worsen. And while you try to manage the respiratory part and restrict the fluids, you will find that the shock is worsening and the organs are failing. So hypoxia, high ventilatory settings, and hypotension is a deadly combination. So could we have done something different for this child to ensure that the child did not reach this stage? So always remember, in dengue, just because you started early, you are not going to reach the shore. Dengue complications cannot be prevented by preemptively putting a child on IV fluids. So whenever a patient with dengue comes to you in a febrile phase, encourage oral fluids. Prefer electrolyte-rich solutions. Especially you can ask for rice gruel, that is kanji water, ORS, milk can be taken. They all contain electrolytes also. Plain IV, plain fluid, plain water would not contain an electrolyte-rich fluid. So because you want the sodium to be on the higher side so that the capillary leak would be less. As far as possible, avoid using IV fluids during the initial phase, febrile phase. If there is a pressing need to start an IV fluid, then just start at 1.5 ml per kg per hour. That is much, much, much less than the normal maintenance fluid. That is, just give enough fluid that gives you a urine output of 1 ml per kg with a stable vitals. And most importantly, do not use hypotonic fluids. Every time you put a child on a maintenance fluid, always remember that the maintenance fluid provides only 20% of the required calories. It does not contain any protein, vitamins, or minerals, and it can cause electrolyte disturbances. And remember that when your gut is empty, the bacterial translocation can happen, and in fact, you may lead on to a sepsis. And use enteral route whenever possible. So if you require to give a maintenance fluid, then the maintenance fluid is always an isotonic fluid. That is a fluid with a sodium between 131 to 154. That means you can either use a DNS or you can use a plasma light. And usually we also ensure that if the kidneys are functioning well, it also requires potassium chloride. That is 5 ml of KCl to 500 ml of DNS. Now, in a dengue, you should know that just like in life, it is a boomerang. Whatever you give will come back to you. Any extra fluid that you give during the initial phases, during the critical phase, either it leaks into the interstitium, causing your worsened ventilatory status in the critical phase, or it gets reabsorbed and may land up in a pulmonary edema during the resorption phase. So the fluid administration should be tailored according to the need. Remember, the rate of fluid administered should match the rate of leak. That means depending on which stage the child has come to you, you should start your fluid accordingly. If the patient is in hypotensive shock, can start with 10 to 20 ml per kg. Absent pulse, you can definitely start with 20 ml per kg. If it is a narrow pulse pressure, only 10 ml per kg is needed. A warning sign, start at 6 ml per kg. And every hour, as the child improves, or you find that the urine output is 1 ml per kg per hour, straight away decrease the fluid to half the previous amount. That is from 6, straight away come to 3. You may again need to go back to 6 or go back to 10, depending upon the urine output status or the vital status. That is okay, because this is what you're expecting. You're anticipating the child to go in and out of shock during the 48 hours of critical phase, but you have to pull through the 48 hours without causing too much of capillary leak. So titrate your fluids according to the urine output is the best indicator of deciding the fluids. Now, so what do you know regarding the critical phase? We said that crystalloids are the first choice, that is normal saline or plasma light you can use. If shock is persisting in spite of 60 ml per kg of crystalloid, then definitely colloids can be used. And shock with signs of fluid overload, just like our child. Our child has presented in shock and already has a puffy eyelid, already has pleural effusion, already has hypoxia. In that situation, you may think of starting with the colloid itself initially. Do not use colloids as a maintenance. Limit colloid to 30 ml per kg per day. For further detailed management of dengue, you can definitely listen to my video on dengue management. Then consider blood transfusion. So in case of dengue, always remember that in all other situations, we always say it is a restrictive fluid transfusion. But when it comes to dengue, we always say it is find a reason to give a blood and give a blood. So indication for blood transfusion in dengue would be any child who is clinically bleeding, give blood. Any child who is in shock but has a PCV that is normal or low also requires a blood, because a dengue child ideally should go into hypotension only because of capillary leak. So you're always expecting a hemo concentration and a high PCV. So even if it's a normal PCV, that means there is an occult blood. So definitely give a blood transfusion. Similarly, if you find that the vitals have picked up but progressively worsening metabolic acidosis, progressively worsening lactate, it again is an indication to give a blood transfusion. So always find a reason to give a blood transfusion as far as dengue is considered. Now coming to the next case, a 3-year-old child presenting to you with a community-acquired pneumonia with evidence of decompensated shock. That means you're dealing with a septic shock. Now the question is, which fluid do you want to give? How much do you want to give? And how fast do you want to? Yes, we are not going to use any of the hypotonic fluids. The options are plasma light, ringer lactate, or normal saline. So if you have a child in shock, whom you are suspecting a hepatic failure or an inborn error of metabolism, avoid using ringer lactate. If your child has diarrhea, prefer ringer lactate, because diarrhea, bicarbonate is lost in the stool. So it's always better to use ringer lactate, because in ringer lactate, the lactate acts as a source of bicarbonate. If you have a child with suspected sepsis with meningitis or an encephalitis, that is, you're suspecting a raised ICP, always preferable to use normal saline so that the sodium remains on the higher side and takes care of the cerebral perfusion also. And whenever you require a large volume resuscitation, preferable to use a balanced solution. Because when you're using a normal saline, remember, normal saline is not normal. Just like it has a higher amount of sodium, it also has a higher amount of chloride. And when the chloride is high, the hyperchloremic acidosis can cause afferent arteriolar constriction. This can lead on to decreased renal blood flow and decreased glomerular filtration rate. So it has been now found that balanced fluid resuscitation is associated with improved survival, decreased incidence of acute kidney injury, and shorter duration of vasoactive infusion. So finally, when you're using a 1 or 2 fluid boluses, it's perfectly okay to use normal saline. But if your child is in shock and is going to require a large volume resuscitation, always keep an eye on the chloride. If you find that the chloride is increasing, change to either ringer lactate or plasma-lite if available, because as I already said, too much of chloride can be harmful. So now we have selected the fluid. Now comes the question, how much and how fast to give? If your child is having only evidence of poor perfusion without hypotension, that means tachycardia is there, but the BP has not fallen. If you're working in a peripheral setup, all you need to do is start the maintenance fluid. If you're working in a tertiary setup, you have to give a fluid 10 to 20 ml per kg over 1 hour. Earlier, we used to say 20 ml per kg over 20 minutes. Now it is 10 to 20 ml per kg over 1 hour. Now, why is it in that the peripheral hospital we are telling to give just start the maintenance fluid? The reason is that because if in the peripheral hospital, if the child is being seen by a general practitioner or someone who's not commonly seeing a baby, he might be missing a child with a myocarditis, a cardiogenic shock, an anemia, a sickle cell disease, conditions where flow or malnutrition, conditions where rapid resuscitation may be harmful. So that is why they say that if you're working in a peripheral setup, especially without a ICU setup, where if the child goes in for a pulmonary edema, you don't have methods to stabilize him. So that is why they said that you can start the fluid at just a maintenance, which would roughly come to 3 to 4 ml per kg per hour. Now, if the child is having a hypotensive shock, then the bolus is always 10 to 20 ml per kg, and the bolus is given over 20 to 30 minutes. Earlier, we used to do a push-pull method. You used to administer it very fast, over 5 minutes. Now it is not done, because whenever you're dealing with a septic shock, there is always a capillary endotheliopathy. And whenever you're giving a rapid fluid administration, the chance of fluid leaking into the interstitium is more. So that is why you want to give the fluid over a longer period of time. In a peripheral setup, the maximum fluid recommended over in 1 hour is 40 ml per kg. In a tertiary setup, the maximum fluid recommended is 60 ml per kg. So I already said why rapid fluid administration is not recommended, because it has been found that rapid fluid administration is associated with increased need for mechanical ventilation also. And so that is why in a peripheral setup, maximum 40 ml per kg over 1 hour. Now, which inotrope would you like to select if your child continues to be in a shock? Now, the question is, now, if the child is having a narrow pulse pressure shock, please start adrenaline. And if you don't have adrenaline, you can start dopamine at 5 to 9 microgram per kg per minute. If the child is having a wide pulse pressure, then start noradrenaline at 0.05 microgram per kg per minute. If noradrenaline is not available, then a dopamine can be started at 10 microgram per kg per minute. Inotropes are titrated every 20 minutes, depending upon the BP. So if the BP is not rising, you can increase the inotrope every 20 minutes. Now, what about if the patient is having absent pulse? That means you don't know whether it is narrow pulse pressure or it is a wide pulse pressure. Remember, you can start either adrenaline or noradrenaline, because it has been found that the time to achieve the mean arterial pressure is same, and the efficacy of both these drugs when used initially is the same. But subsequently, which inotrope you titrate will definitely depend upon a lot of hemodynamic parameters. So whichever inotrope you start early is okay. Now, why we are not talking much for dopamine? Remember, dopamine has now still used in newborn ICUs because it has been found to be equivalent to adrenaline as far as newborn is considered. But as far as adults is considered, or bigger child, or in the pediatric ICUs, dopamine is really not used much. It has really gone out now. The reason is dopamine is associated with a higher 28-day mortality, more of GI reactions, more of arrhythmia. And because of its action that it causes a decrease in TSS secretion, it causes a decrease in prolactin, which is also associated with increased risk of hospital-acquired infections. So because of these reasons, both it is preferred over noradrenaline and adrenaline. Noradrenaline and adrenaline is preferred over dopamine. So dopamine may be started if the others are not available. Otherwise, a direct acting catecholamine is always preferred. Now the next question. So now you know if your child is not responding to fluid, you are going to start an inotrope, and which vasoactive agent you are going to start also you have decided. But now the question is, at what point will you start the inotrope? Will you want to start the inotrope after the first bolus, or after the second bolus, or after the third bolus? Traditionally, we were taught that you have to start the inotrope after 60 ml per kg. But now most of the guidelines recommend that the inotrope should be started as soon as possible when a second line is available to you. But we need to know that what is the literature evidence for this. There are studies which say that early inotrope is associated with a better outcome or better shock correction. But there are also studies which is telling that early inotrope is associated with worse outcome. So how do you balance these two data that you have in your hand? The balance is, remember that in a septic shock, there is always an absolute hypovolemia. What do I mean by absolute hypovolemia? Because septic shock is associated with a capillary leak. There may be associated diarrhea, vomiting. All these are going to cause a decrease in the intravascular volume. So that is the reason why we always say that fluid resuscitation should be done. There should not be any doubt. So in the condition where there is a hypovolemia, starting an inotrope or a vasopressor agent early would be harmful. So if you have your child who is having features of capillary leak, features of hypovolemia, or any child with septic shock, definitely requires a fluid resuscitation first, followed by an inotrope when needed, not early inotrope. But when you come to a classical septic shock, that is when you are dealing with a child with a gram-negative sepsis. Remember, in adult, most of the septic shock are vasodilatory septic shock. In children, most of the septic shocks are not vasodilatory septic shock, where especially when you have a community-acquired septic shock following a pneumonia in a normal healthy child, most often it is associated with a decreased cardiac output state. Whereas when you have a septic shock associated with a diarrhea, probably it is a Shigella or a gram-negative infection. When a septic shock is happening in a child with immunosuppression, when a septic shock is happening in a child with febrile neutropenia, these are conditions, often it is a vasodilatory shock and you require a vasopressor. So in conditions where you have a vasodilatory shock, that is a condition with a wide pulse pressure shock, remember, it is not only the absolute hypovolemia, there is also a relative hypovolemia because of the abnormal vasodilatation. So in this situation, if I start the inotrope early, I would be able to restore the vascular tone early, which would mean that I would require lesser fluid to achieve the same BP target or perfusion target. At the same time, I would be able to restore the mean arterial pressure early. So this was the physiology. So what did we understand? Vasodilatory shock, definitely start vasopressor early. Vasoconstricted shock, hypovolemic shock, start vasopressor only after fluid resuscitation. Now, how do you practically decide? Here, if the patient is having a life-threatening hypotension like an absent pulse situation, you may start a vasopressor early when the second line is available so that the child does not go in for an arrest. If the diastolic BP is less than 50% of the systolic BP, please start the vasopressor early because you would require lesser fluid to resuscitate. If the diastolic shock index is more than 3, also start the vasopressor early. And if your patient has a high risk for fluid overload, that means a patient who has come already with the features of fluid overload, starting an inotrope early would be more beneficial. So now Why am I so much bothered about starting an inotrope early to see that I am requiring less fluid for resuscitation? Because whatever be the condition, whenever you are using a crystalloid, remember only 1/3 remains in the intravascular volume, 2/3 goes to the interstitial volume within 60 minutes of administration. So if I am going to give more fluid is going to reach the interstitium. And fluid in the interstitium is not a cosmetic problem. Fluid in an interstitium is as equally deleterious as a hypoperfusion. So hyperperfusion and hypoperfusion are equally deleterious. Never underestimate the chance of mortality just because of fluid overload. Remember, when the patient is having an increased fluid in the interstitium in spite of being in shock, just like you see your edema, periorbital edema, remember every organ in your body has swollen up. Excuse me. So whenever you have a swollen up organ, naturally the blood will find it difficult to enter the tissues. And when the ascites increases, the intra-abdominal pressure is going to go up, which is going to hamper the splanchnic circulation. That way, it is going to decrease the renal perfusion. And when the intra-abdominal pressure goes up, venous return comes down, the cardiac output also will decrease. So each and every organ in your body is going to be damaged if there is an increased fluid in the interstitium. So that is why from the beginning, always try to give only that much of fluid, which will give you a urine output of more than 1 ml per kg per hour. Not a drop more, not a drop less. Always look for the perfusion. Please do not target blood pressure as your goals. Blood pressures are not the goal. Your goal is tissue perfusion. Always look for the downstream markers. See that the urine output is more than 1 ml per kg per hour. See that the tachycardia is coming down. Your perfusion is improving. Your lactate is improving. Your bicarbonate is improving. So it is important to see that tissue perfusion markers are corrected. Only then we can say that the shock is corrected. So you can see here, there are multiple studies which have shown that fluid overload percentage more than 10% is associated with increased mortality. More than 20% before CRRT even is also associated with increased mortality. So always try to limit fluid overload percentage as far as possible, less than 10%. Now coming to the next scenario, 5-month-old child presenting with poor feeding and lethargy, having features of acute myocarditis with cardiogenic shock. So his extremities are cold. Always we say that whenever you have an unusually cold child, think of a cardiogenic shock, because cardiogenic shock is classically associated with an increased SVR condition. That is why they always appear cold. So baby is having gallop, baby is having basal crepitations and liver of 4 centimeter. Now the question is, how do you plan fluids and inotropes when you're dealing with a cardiogenic shock? So are you going to give fluids for all in cardiogenic shock, or are you going to decide on depending on certain conditions? So the basic principle in management of a cardiogenic shock is that at this point, your heart is like a tired horse. Don't whip it, just support it. So how do you support a tired horse? You have to minimize the demand. If the child is agitated, careful, see if there is any pain, try to alleviate the pain. Mild sedation, remember, shock itself is a sedative. Any sedative is a cardiac depressant. So if you're sedating, be very careful. See to it that the fever is controlled. See to it that when fluid is needed, the fluid is given, the electrolytes and your glucose is maintained. So always minimize the demand. The next is maximize the performance by using the minimum dose of the inotrope. We don't want a high normal BP. We just want that low normal BP, which is going to give me adequate perfusion. Don't whip him. Just give him the minimum dose of inotrope, which is helping you correct the shock. And of course, find the cause and treat the cause. So now, how to first is optimize oxygenation. Remember, for every child in shock, you definitely want a saturation more than 92%. A pure cardiogenic shock or a septic shock, 94 to 98 is desirable. But if you have a child with a cardiogenic shock or a CCF with a left to right shunt, do not give too much of oxygen, because oxygen is a pulmonary vasodilator. It is going to increase the left to right shunt and worsen your CCF. So it should be a controlled oxygen. For a left to right shunt, any saturation between 88 to 92 should be okay. And also remember, anyone with a cardiogenic shock, anyone with a pulmonary edema, of course, support breathing. Support breathing means whenever there is an increased work of breathing, always starting an NIV or a BiPAP or a CPAP is preferable. Because when you are putting a child on a BiPAP or a CPAP, when you have that positive intrathoracic pressure, it is going to decrease the venous return. It is just like giving a diuretic. At the same time, when you're pushing a positive intrathoracic pressure, your heart is now surrounded by a positive pressure. It would find it easier to contract. The systole becomes easier. So it is like adding an inotrope. And the third is now your heart is sitting at a high pressure zone while your abdominal aorta is a low pressure zone. So it is like decreasing the afterload. The heart finds it easier to pump to the aorta when it is sitting at a high pressure zone. So even though the diastolic filling is compromised, a positive intrathoracic pressure augments the systolic function of the heart. So always support the breathing also. Normally, when we breathe, only 5% of the cardiac output goes to support the breathing. But whenever there is an increased work of breathing, more than 14% goes to support the breathing. So if you take away the work of breathing, the blood can be utilized for more important organs in your body. Now coming to the next question. Are fluid boluses indicated or contraindicated in case of cardiogenic shock? So most of you would say, yes, we can give a fluid bolus, but we have to give a smaller bolus and give it over a longer period of time. It's not completely true. Whether you can give a fluid bolus or not will depend upon which physiological state you have received your child. If your child is cold and wet, what do you mean by that? If your child, like our baby, the child already has a hepatomegaly, there is a respiratory distress, there are basal crepitations, that means the child is showing all features of pulmonary edema. So already there is a fluid overload. In that situation, giving an extra fluid bolus would be harmful. So this would be a child there you would like to start the inotrope early. Whereas if you have a patient with a cardiogenic shock whose perfusion is poor, BP is low, but there are no nasal crepitations, there is no pulmonary congestion, definitely you can give a fluid bolus, a controlled fluid bolus of 5 to 10 ml per kg over 30 to 60 minutes. So now another concept you need to understand is that normal Frank-Starling curve, we all know whenever we give a fluid bolus, it leads on to increase in cardiac output because the end diastolic ventricular pressure increases. That is the reason whenever you present a child with shock, we always say start with the fluid bolus. But when it comes to a cardiogenic shock, especially a systolic failure, your Frank-Starling curve is flat, lying down. So in this situation, the heart will be very less tolerant to fluid. Even if the child is at present not in pulmonary edema, when you give a bolus, the chance of going into a pulmonary edema is high. So that is why we always say that give a controlled bolus, watching closely that whether it is increasing the heart rate, whether the liver size is increasing, whether the distress is increasing. Because any of those features, that means you have to stop the bolus there. But also remember that once you have started the inotrope, you're literally lifting up the Frank-Starling curve. That means after inotrope, often these children will tolerate fluids. So post inotrope, carefully observe the child, titrate the child, look at the various dynamic hemodynamic parameters like your pulse pressure variability you can look for the BP variability, you can look for the tidal volume changes, having a change in the pulse pressure if the patient is on the ventilator. So those things can be, that means dynamic hemodynamic parameters can be looked into, and you can decide. You can also look for the peak aortic flow velocity variation in response to respiration to decide whether further fluid boluses may be tolerated or not. So this concept has to be kept in mind. Now comes the next question. What about diuretics? So isn't that a paradox? That is, on one side, you're telling that the patient is in shock, I need to give a fluid bolus. On the other side, you're telling that, no, you have to decrease the preload and give a diuretic. So won't it decrease the cardiac output if you're going to give a diuretic? The basic concept here is that whenever a patient is in a fluid overloaded situation, in a pulmonary edema situation, that means your Frank-Starling curve has gone down. That means now your ventricles are overstretched, because of which the cardiac output has come down, and there is also back pressure in the pulmonary circulation leading on to pulmonary edema. In this situation, if you give an inotrope, you're literally bringing the curve back to the steep position where the heart will find it better to contractile and give you a better stroke volume. So that is the concept of adding a diuretic. That means every time you have a cardiogenic shock with the features of pulmonary edema like basal crepitation, hepatomegaly, increased respiratory distress, along with the respiratory support, it's always preferable to start a diuretic. And in conditions where the pulmonary congestion is associated with a shock, with a hypotensive shock, rather than giving a rapid fluid bowl, rather than giving a furosemide as a rapid push, it is always preferable to give it as an infusion. Now, what is the dose of infusion for furosemide in a cardiogenic shock? I would say in any shock, other than a patient who's having a renal injury, the amount of furosemide needed to cause diuresis is very, very low. So what we normally do, we'll take 40 milligram of furosemide in 40 ml of normal saline, start at 0.5 ml per hour and look at the urine output. You would like to have a urine output between 2 to 3 ml per kg. If you're getting a urine output of 2 ml or 3 ml per kg per hour, that rate is enough. If not, you can slowly titrate. But see to it that you are not giving more than 3 milligram per kilogram per day. And while in an acute situation, over an hour, you can even give 0.1 to 1 mg per kg can be given over an hour. But take my word, most of the time, the amount of Lasix you require to cause a diuresis is just 0.01 or 0.02 mg per kg. Very, very small dose is needed to provide an adequate diuresis. So this part should always be kept in mind. And over the course of time, if the urine output comes down, that is, initially you got a diuresis and subsequently the urine output comes down, your solution definitely is not to go on increasing the Lasix without keeping an eye on what is the total amount of furosemide you're giving over the day. Instead, you have to see why your urine output is coming down, because in that situation, you may be required to give an augmented inotropy may be needed. Your adrenaline may not be if sufficient. You may need to add a milrinone, or you may need to add a levosimendan. And so always ask the question, why? Why is my urine output low? If my urine output is low because too much of fluid on the venous end and too little fluid on the arterial end leading on to pulmonary edema, diuresis is the answer. But if my urine output is low because the forward flow itself is low, then you can see whether a titrated fluid bolus or augmenting the inotropy is what you would be needed. Now, what about vasopressors? So how do you select the inotrope? If the patient with a cardiogenic shock has a minimum 5th centile BP, start dobutamine, because dobutamine is the most cardiac friendly inotrope. Being a short-acting drug, you can easily titrate, and the dose can be anywhere from 8 to 20 microgram per kg per minute. We usually don't start at 8, we don't start at 5, we would start at least at 8. And any patient who continues to be, the contractility remains poor and the urine output is not improved, definitely you can think of adding milrinone or levosimendan. But remember, these are drugs not which you use in the emergency room, but these are drugs that you use in the ICU where you have advanced methods of monitoring. Now, if your patient is hypotensive, then always use adrenaline because it's a direct acting catecholamine. And as the child improves, shifting on to dobutamine would be a good option. Now, is there any indication to start vasopressor? If it's a pure cardiogenic shock, then definitely vasopressor sounds scary because vasopressors are going to increase the afterload. For a heart which is already tired and already the preload problems are there, already the inotropy problems are there, and then you go on increasing the afterload, the heart may fail further. But if you have a cardiogenic shock which is associated with vasoplegia, that means when you have, especially when you have a sepsis myocarditis, in that case, paradoxically, even though there is a decreased contractility, but there is vasodilatation. Remember, coronaries are perfused during diastole, so it is important that you maintain the diastolic BP. So if there is vasoplegia, definitely noradrenaline can be added. And if it is refractory to noradrenaline, vasopressin can also be added, but titrate very, very carefully. And it is always preferable not to use dopamine in case of cardiogenic shock. So from there, we move on to the last case. 6-month-old child admitted with acute diarrhea in the ward. The child is, he's on formula feeds. Many of the babies now we encounter is definitely in this scenario. So he was advised to give formula feeds 2 hourly with ORS 2 ml per kg per loose tube. But the child had high purge and child went in for severe dehydration with hypotensive shock. which was initially resuscitated with a 1 bolus of normal saline followed by ringer lactate, and the child was shifted to the ICU. When you receive the child has all the features of severe dehydration, and when you get the sodium, the serum sodium level at the time of admission to ICU sample is 180 milliequivalents per liter. Admission sodium was 126. Where did you go wrong? You have written fluids, you have written ORS, and where did you go wrong? But unfortunately, this was a 6-month-old child with 3.5 kg weight. So please give a role. Please give always in a young infant, especially in a young infant, see whether the child is having a failure to thrive or not. Any child with severe malnutrition who comes to you with diarrhea, if you resuscitate them just like any other ordinary child, you will land up in a hypernatremic situation. So whenever you have a child with severe malnutrition, remember ORS is a prescription drug. It should not be freely available for a child with acute malnutrition. Never use the standard low molecular weight ORS. It is always preferable to use Resomal. That is, how do you prefer a Resomal? That is half strength ORS with added potassium and glucose. So usually dilute 1 liter of ORS in 2 liters of water, add 50 grams of glucose and 40 ml of mineral mix solution. This would give you a Resomal, which is the one which is preferred to be as a rehydration fluid, oral rehydration fluid for a child with severe malnutrition. So here the child had received ORS, and when the child went in for a dehydration, the rehydration fluid used was normal saline. That also contributed to the hypernatremia. Also remember, whenever you have a child with severe malnutrition, it is very difficult to assess the dehydration status, because a child with marasmus will always have a sunken eye. A child with marasmus, the skin turgor will always be prolonged, so you cannot assess the dehydration. On the other side, a child with kwashiorkor would have edema, which would make the skin turgor look normal, and it will be difficult for you to assess. And these children are apathetic, so they might not drink even when they are having dehydration. So what is the best method to assess hydration status of a child with malnutrition? The best method is definitely to meticulously check the weight. So you have to intermittently check the weight to decide whether your hydration is happening appropriately, whether you want to increase the rate of fluid administration or decrease the rate of fluid administration. Remember, unlike other cases where you try to correct dehydration over 4 hours, in a child with severe malnutrition, you correct dehydration only over 10 hours. So how do you decide the rate of fluid administration? Start with 10 ml per kg per hour. Remeasure the weight. If the weight gain is happening, continue. It's the same 10 ml per kg per hour till the pre-diarrheal weight is attained. Now, if your child after the first bolus is showing a weight loss, that means 10 ml per kg per hour is not enough. We have to increase by 10 ml per kg. That means it will increase to 20 ml per kg, and you will continue that till again the pre-diarrheal weight is attained. And if you find that the weight has not increased, weight has not decreased, weight remains the same in spite of a bolus of 10 ml per kg, that means you have to increase the fluid administration by 5 ml per kg per hour. As I already said, the final target is pre-diarrheal weight, because clinical estimation of dehydration in a child with severe malnutrition is very difficult. Also, remember, as I already said, the fluid is not half ORS. It is not ORS, it is half ORS, which you should be using for replacement fluid. For resuscitation, it is never normal saline. It's always preferable to use half DNS or half RL with D5. Remember, these are children who go for hypoglycemia very early because their glucose store is very less. So that is why this is the only situation where you use a dextrose-containing fluid for resuscitation. And this is one of the only rare situations in pediatric ICU. For maintenance, we use isolate P. In all other situations, we do not use isolate P. And always watch out for overhydration or fluid overload also. So that was, in summary, how you select fluid and electrolytes in the ER. I hope a basic idea has been received by looking at the various scenarios that we discussed.